Hi, welcome to this video snippet on neurological symptoms. We'll be looking at the symptoms themselves, their significance, and also their sources. And we'll be looking at some particular syndromes and conditions that we have a more specific interest in, not necessarily because they're common, but because they're potentially very dangerous. And we need to refer them out as quickly as possible. So let's move on. Okay, so the symptoms themselves. I'm not going to explain each one of these until we can do that when we meet. But you'll see that they're in different types. So the first 5 are in italics. These are desensitization sensations. So you lose innervation and you get these symptoms to replace it. Paresthesia for tactile, dysgeusia for loss of taste, parosmia for loss of smell, tinnitus for loss of hearing, and scintillations for loss of vision. Dysesthesia, allodynia, and hyperesthesia, all those underlined, are mostly caused by central sensitization problems. So allodynia, for example, is where everything is painful. Doesn't matter what the stimulus is, it's felt as pain. This occurs in acute pain states, acute rheumatoid flare-ups, fractures, like very severe pains. They also, similarly with dysesthesia, where the sensation felt is different from the input. So you can feel pins and needles when you stroke somebody's arm and they'll tell you it's sort of tingly feeling. And then hyperesthesia, where all sensations are felt as more extreme than the input warrants. These also can be caused by neurological disease processes as well. But often there's central sensitization. So time, duration of the input also plays a role in how bad these symptoms are. Dizziness can be a neurological condition. It can be a peripheral or a central neurological condition, or it can be peripheral. Simple messing up of the otoliths, for example, can cause this. Infections of the middle ear and so on. Labyrinthitis, Meniere's disease, are all examples of peripheral dizziness, whereas VBI, tumours, particularly cerebellopontine tumours, will give you neurological disease, neurological dizziness. Similarly, nystagmus can be neurophysiological. The vestibulocular reflex gets screwed up during vertigo, so you're spinning and the eyes will try to catch up with the image. So this is neurophysiological rather than neurological, or they can be caused by neurological conditions similar to dizziness. So the dark types, the bold-faced type, are all neurological problems. Migrainous auras obviously are less severe than some of the other neurological conditions, but nonetheless they're neurological in origin. And then any others that you want to consider, we can discuss those when we meet. So if we look at the source, common causes and common signs and symptoms, this is what this table shows. So peripheral nerve, so peripheral neuropathies caused by both mechanical stressing, compression, traction, lacerations, angulations, and also by disease states such as diabetes, vitamin 12 deficiency are probably the most common cause of these. The distribution of the signs and symptoms will be in a peripheral distribution. The major symptom here is going to be coursalgia or possibly paresthesia because of the sensory loss. In fact, probably paresthesia as well as coursalgia. On the signs, which we didn't really want to talk too much about, I want to compare this with spinal nerve root. The weakness can be very, very severe because there's no backup to the peripheral nerve. So if you severely damage a peripheral nerve, there's no other input going into the muscle or the skin. You can actually have anesthesia and paralysis rather than just hypoesthesia and paresis. Spinal nerve root, again, disease is much less common than ordinary mechanical compression, but things like shingles and sometimes quite rare tumors on the meningeal sheath and on the nerve root itself. Otherwise, stenosis and disc herniations are the obvious major causes of this. Segmental distribution of the symptoms, the neuropathic pain that you can get from this tends to be lancinating, so it's a severe electric shooting pain. The dura, though, can give you a much more achy sort of pain. It can be very severe, but the pain from the dura tends not to be that electric shock. You'll tend to see not paralysis or anesthesia, but hypoesthesia and paresthesia, and there may be some degree of hyporeflexia. Atrophy is much less severe and it may not be noticeable. Plexus and cord requiner, these are both basically peripheral nerve problems. It's just that these are in the makeup of the peripheral nerve. So again, this can be diseases, tumors in particular, especially in the neck, or mechanical. So disc herniations may catch the early part of the plexus, but it's much more likely to be a disease process than a mechanical obstruction. Of course, in the neck, you do have thoracic outlet syndrome, which can, of course, be mechanical, particularly on the first rib. And there's an argument for muscles doing this as well, but it's not a particularly strong argument, I don't think. Anyway, it's a non-segmental distribution. Of course, how exactly the distribution of this depends on which part of the plexus is injured. Again, the weakness and sensory loss can be severe, and so can be the atrophy, or they can be fairly minor, depending on the severity of the damage and exactly where this is occurring. Spinal cause, disease and mechanical problems, disc herniations, can do this, particularly in the neck, much less commonly in the thoracic spine. Disc herniations causing neurological problems tends to be very, very rare. I think these are somewhere around 1 in a million, something like that, but it's an extremely rare problem. But in the neck, because of the way the facets and the unconvertible joints line up, posterior herniation of the disc are more common than posterolateral in the upper part of the neck, so they tend to go back near the cord. In both cases, though, a lot of this depends on the size of the spinal canal. If it's congenitally small, then central herniations are more likely to produce more severe problems. Distribution can be bilateral if it's from the neck, or actually lower down in the thorax, of course, trilateral or quadrilateral. The biggest symptom is going to be paresthesia, but again, you may see weakness, sensory loss, hyperreflexia, some spasticity if you try to provoke it. Brainstem, vascular, particularly VBI, which we concern ourselves with more than probably any other condition, and then brainstem concussions and damage. So again, causes are VBI, structural and non-structural injuries to the brainstem, causing either a major structural problem in the brainstem, which we're not likely to see, or a concussion or a minor brain injury. Signs and symptoms. VBI is lateral medullary or Wallenberg syndrome, and this is a mix of long track and cranial nerve signs and symptoms. In all cases with the brainstem, though, the cranial nerves will be on one side and the long track signs are on the other. And Horner's may play a role with Wallenberg's, as the thalamus can get involved here as well. So, and then finally the cerebrum. TBI and concussion caused by tumors, basically trauma, just straight trauma, mechanical trauma, or intracranial bleeds. Concussion and TBI will involve memory deficits, cognitive problems, and so on. And we'll talk about concussion more in a second, but it's actually one of those subjects that is really seriously messed up, I think, in the literature, and particularly on the internet. Bleeds tend to produce progressive headaches, which often are gravity dependent. That is, depending on where the thing is. If it's on the side of your head, if you lay down on that side, the weight of the brain will push on the hematoma and produce more headaches. If it's in the front, bending forward, so your shoes up, for example, may do it. The headache is progressive, it gets worse gradually, and drowsiness then comes on, and then you get progressive cognitive loss and motor dysfunction. You want to get them out of there way before those things actually kick in. So if we look at the conditions that we're probably more interested in, others, intracranial bleeds. These are slow subdural bleeds. They tend to occur in older people because of the structural changes with age as the brain shrinks. The veins connecting the brain to the dura get stretched because the dura is attached to the cranium. The brain moves away from it as it shrinks, and these are stretched out. So torque and shear forces are more likely to damage these when you're older than they are when you're younger. So these can go 3-4 weeks before the patient actually collapses with the effect of the bleed. They can be really quite slow. So as I said earlier, it's a progressive, gravity-dependent headache, drowsiness, cognitive and motor difficulty. Recognize these for what they are early though. Go with the progressive headache. There aren't many progressive headaches that will walk into your clinic that are benign. Tumors, bleeds, CSF leaks from trauma and so on. These are not the best things you want to hang on to. So any headache that is getting worse all the time, fire it out. Concussions, the headache tends to be generalized. You can tend to get type 2 or pre-syncope dizziness, nausea, and so on, lightheadedness. The other symptoms are more variable, but make sure there are no neurological signs. So you want to do a neuro exam, including the brainstem and including the cerebrum. If you've got any signs, don't accept this as concussion, fire it out to the emergency room. VBI, symptoms, neurological symptoms with hindbrain strokes come on late usually. So the only symptoms a patient may complain of is headache, which tends to be in the post-occipital area and is extremely common, and dizziness, which according to a number of studies is there 100% of the time with traumatic VBI, not necessarily non-traumatic VBI, but with traumatic VBI. And the dizziness can be type 1 or more commonly type 2. So if we're getting these two symptoms coupled together in a post-traumatic patient, the headache and dizziness are irrevocably linked together, but they're separated from the neck pain, then you really want to basically fire this out and let somebody else sort it out for you. If all three are connected, then it may still be VBI, if all of these are completely associated, because the artery damage itself can be painful. But this is unlikely to be the pain that the patient's complaining of. So this one gets a little bit more tricky to handle, but that combination of dizziness and headache is something you want to be very wary of. It does impel you to a cranial nerve exam. Okay, so if you're finding cranial nerve signs with a deliberate exam, don't move the patient around. The cranial nerve exam, when they're dizzy, if you can manage it, then fire it out. Symptoms are from a lateral medullary syndrome, so we're looking at hemilateral paresthesia. Dysphagia is common. Hiccups are interesting. These can be uncontrollable with lateral medullary syndrome. So I'd take that as a specific, personally, if this is an ongoing problem. Horner syndrome, very, very difficult to spot, and we'll talk about that a bit more in a second, but it can be extremely difficult to see. Lateral ataxia and other variable brainstem syndromes. Core compression, bilateral, trilateral, or quadrilateral paresthesia, and with stenosis, rather than traumatic compression of this, the only symptom in an older patient may be tripping, and it comes on for no good reason. Test their balance. If their balance is good, then assume that this is a muscular problem, either a neuromuscular incoordination or it's weakness and the muscle endurance is lost because of innervation problems through the cord. Get it out. And then also have the other symptoms of a stenotic problem, aching in the neck and the arms and so on. Cord requiner syndrome. The symptoms are going to be bilateral, and it will be pain, possibly neuropathic pain, but more likely non-neuropathic pain for the dura, but paresthesia. Now, this paresthesia will include saddle paresthesia. The patient is unlikely to tell you about that, and they certainly won't say, I've got pins and needles in the crotch as the only symptom. This will be pain down the legs, and you may have to ask about whether or not they're feeling it in the saddle area. There may be no other symptoms, but you can ask about in the early stages anyway, but you need to be asking about either incontinence, urinary and fecal incontinence, or urinary retention. So there's an urgency to go, but not much happening, because you can get a mixed upper and lower motor neuron if the phylum is particularly long and well developed. Horner syndrome, there are actually no symptoms for here, but I've got to include it simply because we've had to talk about BBI. No symptoms, but endothalamus, meiosis, anhidrosis, facial reddening, and ptosis. Now, endothalamus, the eyeball looks retracted, but it's believed to be an illusion, an optical illusion, caused by the small pupil and the ptosis, making the eye look further away. The meiosis itself can be difficult to spot because it's quite a small meiosis, and often it has to be seen in a darker light, so the normal pupil will open up and give you a better comparison. Anhidrosis can be difficult to see, and you might have to run your fingers down the face and look for which side is catching, particularly in dry areas. Facial reddening can be difficult as well, and the ptosis is quite small and may not be apparent unless they're tired. Pancoast syndrome is an apical lung tumor that comes up, compresses the ganglion, the inferior cervical ganglion, and the brachial plexus, part of the brachial plexus. So you get evidence of Horner syndrome plus evidence of a brachial plexopathy. So I hope this is helpful to you, and we'll talk about this when we meet. Okay, take care, everybody. Bye-bye.